Hello everyone, welcome to MSART's 11th webinar, co-organized by Merck. Before we commence today's session, I am delighted to share some exciting updates regarding the MSART 2024 conference. This year, our team, Looking Within to Grow Beyond, emphasizes transformative changes, both large and small, that can significantly enhance our daily operations. The MSART 2024 conference will be held on the 5th and 6th of October at the Sunway Pyramid Convention Center. We have curated an impressive lineup of both local and international speakers who will present a variety of engaging topics. Our keynote speaker, Professor Dr. Kazuhiro Kawamura, Professor of Obstetrics and Gynecology in Juntendo University, Faculty of Medicine, Japan, who will deliver a particularly intriguing lecture entitled In Vitro Activation, Current Trends and the Future. This conference presents an excellent opportunity to expand your knowledge and establish valuable connections within the industry. Pre-registration is currently open, so I encourage you all to register your interest today and be among the first to be notified when official registration begins in August. Next, I want to highlight our upcoming August webinars. On August 15th, we will host a session with Dr. Wan Shahira Yang Mohsin. She's a consultant ONG and fertility specialist at Alpha IVF and Women's Specialist Center and Al Haya Fertility Center. She will speak on reviving hope in vitro activation. Registration for this webinar will be open soon. Our final webinar of this year is scheduled for the August 29th, 2024 by Professor Christophe Blockhill, Professor and Medical Director at the Center of Reproductive Medicine, UZ Brussels, will present on optimizing success in ART, real-world insight on the treatment of personalization with highly purified HMG. Registration for this session will be open shortly. Now, regarding today's agenda, today's webinar, we are pleased to have Dr. Tham Seong Wai, who is a consultant ONG and Head of Reproductive Medicine Unit at the ONG Department in Hospital Raja Permaisuri Bainun in Ipoh. He will present on important topic of personalized luteal phase support, optimizing outcome and improving satisfaction. While Dr. Tham is presenting, please feel free to submit your questions in the Q&A box. We will address them during the Q&A session at the end. I'd like to introduce Dr. Tham. Dr. Tham is a consultant ONG at in Ipoh. He obtained his MBBS from Trivandrum Medical College in Kerala and then completed his master's in UKM, and following which he did a fellowship in Reproductive Medicine Australia. He's the head of Malaysian National Reproductive Medicine Subspecialty Training Committee, Reproductive Medicine representative for the MMC, and supervisor in the National Reproductive Medicine Subspecialty Program. He is also the honorary lecturer in UniKL and Sultan Azlan Shah College of Health Sciences. He has received Excellent Service Awards on 3 occasions and has conducted and published research papers related in ONG and reproductive medicine. So without further ado, I'd like to welcome Dr. Tham to give his presentation.
Hi, good evening, everyone. Okay. So let me get my slides up first. Can you all see my slide?
Yes, I can.
Okay,
very
fantastic.
Clear.
So let's start. Now, tonight I'm going to talk about the, first of all, let me thank Dr. Navdeep. Yeah, sorry, Dr. Navdeep, for the kind introduction. And let's start with this topic, which is personalized luteal phase support, optimizing the outcome and improving satisfaction. So the outline of what I'm going to talk about tonight is, number one, we got to know what is the luteal phase effect, the guidelines on luteal phase support, the characteristics when we do FET protocols, because each one is slightly different, the forms of progesterone supplementation, as well as, lastly, we are going to look at the clinical evidence of vaginal progesterone 8% versus all the other forms of progesterone. Okay, Now let's start on the human corpus luteum. I think this is back to basics for all of us. Progesterone secretion, of course, we know is maximum during the mid-luteal phase. So you will find that the progesterone level rises to about 40 to 60 nanomoles per liter in a natural cycle. And this progesterone is absolutely essential for the endometrial decidualization preceding the implantation. That means the progesterone prepares the uterus to receive the embryo. Now, if you look at progesterone, how it induces the secretory maturation of the endometrium in a natural cycle, the corpus luteum after ovulation will produce progesterone. And this progesterone induces a cascade of molecular events that makes the endometrium thick and receptive with enough vasculature to receive the embryo when it comes into the uterus. So after implantation, the progesterone stimulation will continue to rise because of the increasing concentrations of HCG. And this will support the growth of the implanted embryo. Now, the luteal effects of progesterone. So progesterone transforms, what does it do? It transforms the endometrium into the secretory phase. It also plays a very important role in regulating the window of implantation. Now, this is the very important phase where the uterus or the endometrial lining in particular has a few days which allows the implantation of the embryo. If you miss this window of implantation, either it's too early or too late, implantation cannot occur. Progesterone also increases the endometrial vascularization. It is a very good immunomodulator. That is why you will find that the embryo, which is half coming from the father, from the male, of a different immune level is accepted into the uterus. Okay, this only occurs in pregnancy where the woman's immune system accepts a foreign what you call a foreign body to enter it without causing an immune response to destroy it. So progesterone plays this immune modulator role. And we know very well that it reduces uterine contractions when the implantation is occurring and also immediately after the implantation occurs. So ovarian stimulation protocols definitely do affect the luteal phase. It is very well established that when we stimulate the uterus, when we do ART for our patients, it definitely alters the luteal phase. The luteal phase will not follow what a natural cycle does. So this ovarian stimulation, it causes an inadequate development of the endometrium. There will be an asynchrony between the endometrium and the embryo when it is transferred. So this will also affect adversely the endometrial receptivity. So this is a graphic diagram on what happens. When we stimulate the ovaries, we get superovulation or recruitment of high numbers of follicles. So this causes supraphysiological steroid levels. The estrogens will be very high, progesterone too, and this will in turn cause very low mid-luteal LH levels. If you look at a natural cycle, the natural cycle has 6 international units per liter of LH. When you use a GnRH agonist trigger, it drops to 1.5. If you use a HCG trigger, it drops to 0.2. So these very low levels of LH during the mid-luteal phase will produce a luteal phase defect. Now, what do we mean by the word luteal phase defect? A luteal phase defect means that in a natural cycle, we know the mid-luteal progesterone levels will be less than 10 nanogram per ml. Sorry, what I meant to say is, when you have a defective luteal phase, the mid-luteal progesterone level will be below 10. The normal levels will be much higher than 10 nanogram per ml. The mid-luteal progesterone levels, however, do not always reflect the endometrial maturation. The most reasonable consensus on a defective luteal phase is when histologically you will find that there is a 2 days difference from.
Sorry for interrupting, Dr. Tham. Can you share the second screen? Because we are looking at the presenter's screen.
Okay, hang on. Yeah.
The other one. Sorry.
No worries. Okay, second screen. Okay, yeah. Okay, this one, right?
Yes, excellent. Yes, yes.
Okay.
Thank you.
So, yeah, coming back to this. Therefore, when we look at it, luteal phase defect, most reasonable consensus on defining it is when you find there's a lag of 2 days between the histology of the endometrial development as compared to the expected day of the cycle. Meaning, if you are on day 16, your endometrium is only on day 14. So there's always a lag. So the next question, progesterone administration, is it important in ovarian stimulation? When it comes to ART, the answer is a definite yes. So progesterone has been found to improve the pregnancy rate in IVF cycles compared to no supplementation. This has been published long ago in the Cochrane Database Systemic Review in 2015. Okay, next, we look at the luteal phase progesterone in a natural cycle compared to a HCG triggered cycle. Now, if you look at this is an IVF cycle. This is a normal cycle. So you will find that because of the supernumerary follicles that are stimulated and the supraphysiological levels of steroids, there is an abrupt drop in the level of progesterone. As compared to a natural cycle, the progesterone eases out later on during the cycle. So the gap between the sudden drop as compared to the natural cycle is what we call the luteal phase gap, where the embryo does not have enough progesterone to encourage it to implant and grow in the endometrium. Now, if you look at this, there was a Delphi consensus looking at optimizing follicular development, pituitary suppression, triggering, and luteal phase support during ART. 75% of the people agreed that vaginal progesterone therapy represents the gold standard as the luteal phase support after IVF or ICSI. And the route of progesterone administration does not influence outcome. So it tells you the importance of vaginal progesterone when it comes to IVF ICSI cycles. Now, preparation of endometrium for FET. Most of us will use one of these. Mainly, we are going to go for the HRT. Some of us will choose the natural cycle, or we can even use the mild stimulation. Now, if it's the HRT cycle, there's no issues in it because we will give the HRT, and then when the endometrium is ready, we will supplement with the progestogen. However, in the natural cycle or the mild stimulation, remember there's a corpus luteum there. So it is mimic of a natural cycle. There will be a gap, and this gap you need to cover with progestogen, yeah? So next, we look at a study done looking for the optimal preparation and timing of endometrium in frozen cord embryo transfer. So this is a literature review of clinical evidence. Of course, you have the true natural cycle, modified natural cycle, mild stimulation, and the HRT. So what I want to bring you all to is, this is a busy slide. Look at the luteal support. It says that in a true natural cycle, the luteal support may have some benefit, but you need more studies. In a modified natural cycle, might not have any benefit, but more studies needed. In mild stimulation, you might have some benefit, but more studies needed. And in the group where we use HRT, continue progesterone administration until luteoplacental shift. So if you were to look at all these stimulation cycles, especially for those of us who are using the HRT cycle, I'm not sure, but I use a lot of HRT cycle. I don't know about the rest of the audience out there. So progesterone administration is absolutely essential because there's no corpus luteum to produce the progesterone. And the best method of luteal phase support, well, it is not a single answer correct question. Luteal phase support, you need to make sure it is efficacious, it is safe for our patient, acceptable route of administration, and of course, cost. Nowadays, Malaysia is having some economic downturn, so cost is very important. A lot of my patients talk about cost, yeah? So these 4 factors will influence our luteal phase support decision. So let's look at the different forms of progesterone supplementation. You have got the oral form, the vaginal form, the intramuscular, and subcutaneous. Of course, we know very well that if you take it orally, it goes through the liver. We wonder how much goes back into the bloodstream. And of course, it has got side effects, hypnotic side effects, sedation. And what is not written here, a lot of my patients complain of constipation because it also decreases the peristaltic effect of our GI tract. Sorry. However, a lot of us use it because it is a very easy and convenient route. Vaginal. Now, this is very important because it has the first uterine pass effect, where we have a high concentration of the progesterone in the uterus, and that is the target organ where we want the progesterone to be. So, of course, it is highly available, as said just now, in the uterus and endothelium, fewer side effects, and it has a very good patient compliance. Now, let's look at the IM. IM very rapidly absorbed, reliable and consistent plasma levels of progesterone. However, whenever you give an IM, you will find that there's always a local reaction because it is oil-based, and there's always a risk of getting an abscess. And the patient cannot self-administer. The injection is painful, you will get swelling, you will get rashes, and it's uncomfortable. Subcutaneous, rapidly absorbed, serum levels are above the threshold, and more than 50% patients complain of discomfort and redness, itchiness at the site of injection. The good thing, it can be self-administered. So now, having looked at all the different forms, we look at the HRT FET cycle, looking at the route, doses, and types of progesterone administered. Vaginal progesterone, as we know, first pass uterine effect. You have got the gel form, you have got the capsule form, and you have got this suppository form. Now, most of us or all of us will use this, plus either an intramuscular progesterone or a subcutaneous or the oral progesterone, dydrogesterone. Okay. Now, if you look at the IM, there were 5 RCTs, vaginal progesterone versus IM progesterone. Both had comparable efficacy, except for one study. If you look at the subcutaneous progesterone, there is no dose-finding study done yet to date. So we don't actually know what is the actual dose that is needed for luteal phase support and comparative RCT in HRT cycle. Yeah, so we don't know. We have not much, or let's say no evidence on the dose finding, the dose that is necessary. The oral dydrogesterone, again, there's no dose finding. Some people give it twice a day, some people give it 3 times a day. There was one pilot study, but it was small scale and it's a comparative study. So we do not have any dose in these two groups to know what is the exact dosage that is needed. We just empirically use it as per what our colleagues say or as per our reading. So overall, there is scarce comparative data that tells us anything on the different routes, doses, and types of progesterone. So this complicates a lot of things, yeah? So let's look at what ASHRAE has said in October 2019. Strong recommendation. Progesterone is recommended. No doubts about it. We will need, whenever we do IVF and ICSI for the above mentioned reasons, we will need to supplement progestogen. And the routes and the frequency, well, that is a general practice, depending on what you practice. And if you look at when should we start, it is suggested that you start on the day of oocyte retrieval or as late as no later than 3 days after oocyte retrieval. Okay. And dydrogesterone is probably recommended for luteal phase support. Okay, now there was a study looking at the luteal phase support in IVF, comparing what the evidence-based medicine say and what real-life practices are. Because the keyword now is everybody wants to talk about the real-life practice. Okay, so the vaginal administration appears to be the preferred route of administration of progestogen, where 80% of the clinicians like prescribing vaginally. Again, just to tell you how important the Delphi consensus is, 75% agree that vaginal progestogen is the way to go. And this Delphi consensus was made in 2021. Now, the next question, when do we start luteal support? As I mentioned just now, we usually start it on the day of OPU or no later than 3 days after OPU. So there was this study published in 2015 looking at the timing of luteal support in ART. You will find that majority of the clinical pregnancy occurs when you start the progestogen from the day of pickup to roughly about the 3rd day of OPU. Now, why does this happen? Because if you see, you give the patient a HCG, there will be a HCG rise. And this HCG will drive the progesterone up. However, the progesterone will drop quickly as the HCG level drops. So the progestogenic rise due to the drive from the HCG, when the HCG drops, progesterone will follow. And when you compare it to a natural cycle, you will find that there will be a gap where you will need to supplement. We need to know that the progesterone level is 100 nanomole per liter to be effective. So we need to supplement during this period of time the progestogen to make sure that there is sufficient progesterone for implantation and for the ongoing pregnancy. Now that we know when to start the progestogen, we should also know when to stop. There is no hard and fast rule. There was a study done, luteal phase support in IVF, comparing again real-life practice versus evidence-based medicine. And if you can see, 12 weeks. That's the maximum that people go to. So if you talk about evidence, there might be a lack of evidence supporting continuation of luteal phase support until 12 weeks. However, they have done in real life, most of the clinicians will still stick to 12 weeks. And this is the time when there is a luteal-placental shift, where the corpus luteum shifts over, or the progesterone given by the corpus luteum shifts over to the placenta. So they feel that they need to give it until the placenta is able to take over the function of the corpus luteum. Now, let's go to what is progesterone 8% gel. Progesterone 8% gel is a progestogen which is entrapped or encased in a cross-linked polymer polycarbophile. Now, this is a gel. So the progesterone is put into the gel, and this gel, which is water soluble and water insoluble, will stick to the vaginal mucosa and slowly, in a sustained manner, release the progesterone to the tissue. Now, it is proven to be very good as a once daily application of vaginal progesterone. So as I said, the gel sticks to the vaginal mucosa and therefore releases in a controlled, stable manner the progestogen. When you compare the vaginal progesterone versus the oral, you will find that it is having a more prolonged level after administration as compared to the oral. Now, the drug diffusion study done by Buletti, this was in 1997, where they put some radioactive test substances and attach it to the progestogen, and they found that there is a very high concentration of the progestogen within the uterus, which is our target organ. Therefore, it is a targeted delivery system to the uterus for luteal phase support. Now, let's look at the serum level as well as the tissue level, comparing IM and vaginal progestogen. If you look at the serum progestogen, the IM progestogen will win hands down. It is absorbed quickly. It gives very high and very stable serum levels of progesterone as compared to vaginal. But what is more important, it is the level of progestogen in the endometrial tissue. So you will find that the endometrial content of progesterone after the vaginal progestogen is much, much higher than the IM. It is concentrated in the uterus. So now let's look at the clinical pregnancy rate and implantation rate between the vaginal progesterone and the progesterone gel. You will find that in this study by Wang LJ, published in 2009, there is a 14.4% higher clinical pregnancy rate in the vaginal progesterone gel. There is also an 8.15% increase in implantation rate in the vaginal progesterone gel as compared to the vaginal progesterone capsule. Next, let's look at the intramuscular progesterone versus the vaginal progesterone gel. Wang et al. Published this paper, which looked at it's a prospective randomized clinical trial of 1,500 cycles, yeah? And they found that the clinical pregnancy rate between the IM progestogen and the vaginal progestogen is definitely comparable. Or the pharmaceutical people will call it non-inferior. So what about you compare all of them? So Shiba published a paper in 2020. They look at the gel, the capsule, the pessary, as well as the tablet. So they found that all of them, the clinical pregnancy rate is comparable. So it tells you that the vaginal route is definitely the most efficacious, and it does not matter much which you use. What comes to the boiling point will be whether the patient likes it or not. So once daily vaginal progesterone gel, there was a cohort study looking at 285 women published in 2007, looking at how easy is it to administer. Almost 90% said it's easy. 93% said it's very convenient because once a day. 75% said not so messy. 85% said I prefer this method. So let's look at what are the problems related to vaginal progestogen and vaginal suppositories. Inconvenience of administration. If you look at day 6 of administration, after administering 6 days and after administering 16 days. Within the first 6 days, almost 60% say no issues. Almost 40+% said no issues. And very minimal said moderate and 0 said severe. This is for the vaginal progesterone gel. If you look at severity of the what you call on day 16, on the symptoms, the inconvenience, you will find that again the progesterone gel, close to 70% said no issues at all, no inconvenience, and mild only about 40%. So it tells you that the patient do not feel inconvenienced by using the progesterone gel compared to the suppository. What about this messy thing where you find this what you call oily substance and clumps coming out from the vagina, leaking out from the vagina? Again on day 6, 40+% said no issue, 60% said mild, none said moderate or severe. On day 16, again the same thing, 50+% said no issues, and 40+% said only mild. So it is a much tolerated method of progesterone vaginally. So take home message, luteal phase support needs to be adjusted to the person. Again, looking at the safety, the cost, the efficacy, as well as what the patient wants. Then number 2, luteal phase support definitely needs to be given, especially when you do IVF, ICSI. And number 3, vaginal progesterone is the gold standard when it comes to luteal phase support. With that, I thank you for your attention.
Right, thank you very much, Dr. Tham, for the insightful presentation. Any questions from the floor? So far, they are. Let's have a look. No, there are questions. Okay, question number 1. Hi, Dr. Tham. As you mentioned from the graph, the serum P4 is low with vaginal pessaries, while the endometrium P4 is high. Do you still do the serum P4 for patients before and after transfer of fresh and frozen ET cycles? P4 will be a reference to increase pessary or other methods of progesterone administered to boost the P4 level? To increase the pessary or other methods, do you increase the levels according to your P4 level?
Okay, so there are two answers to that question.
Hmm.
As I mentioned earlier, progesterone, when you have a very low level, below 10 nanogram, then you need to supplement it. However, it is also stated that the level of progesterone in the serum might not reflect what you have in the endometrium. So as a rough guideline, I think most of us will do a progesterone level. And if we find that it is low, definitely we will supplement, or I will supplement, and I suggest supplementing the progesterone. Because if the progesterone is low, you do the level and it is low, and you do not do anything, and there's no pregnancy, the patient going to come back to you. Because they will say that you noted that the progesterone is low, but you did not supplement it. So my suggestion, please do supplement. That is the only way we can look at it. We can look at the levels, whether it is sufficient or not.
Yeah. Next question is, what was the progesterone tablets, 100 milligram TDS used in the study, comparing the other progesterone vaginal and IM administered?
I couldn't find the name of it, but I think it is available in the European countries. I can't get my name on it. I will get back to you all regarding the name of the tablet, because I don't think it is available in this part of the world.
I think it's endometrine, not mistaken.
Yes, it
Endometrine
is
was 100 milligram.
Yeah. Endometrine was used. However, I think in Malaysia, I don't know. Do you use a lot of endometrine? I do
Used
not
to have
much.
it, but yeah.
Mm.
The next question is, I need more explanation about other types of FET cycles rather than HRT, please.
Other type, okay. So you have got a natural cycle. The natural cycle means you do nothing. You monitor it. You look for the follicle. And some of us will trigger the follicle when it matures or when it reaches 18. And some just don't trigger. They will wait for ovulation. When you see that the follicle has disappeared and there's a bit of fluid in the POD, then you will start your progestogen and you will time for the transfer 5 days later if it's a day 5. 3 days later if it is day 3.
Yeah.
Okay. Then you have got the minimal stimulation. The minimal stimulation will be, you will give either clomid or letrozole. Some people give chicken feed dose of FSH. And it is just like an IUI or time coitus cycle, where once the follicle grows, you will trigger, and then again you will time it, similar to the natural cycle. Then you got the FET cycle, the HRT cycle. There is one more called the modified natural cycle, where you trigger with HCG. The true natural cycle, you don't trigger.
Yeah.
So these are roughly the 4 types. The HRT can be given in 2 forms. You can give oral, you can give vaginal, or you can use combination.
All right, thank you. Next question is, when should we start the vaginal progesterone in an FET cycle?
Vaginal progestogen, okay. What was given just now, if you can see, there is a period for starting the progestogen, which is on the evening of pickup of your OPU day, and no later than day 3 of your pickup.
Yeah.
That is the window, because the progestogen rise due to the HCG will drop very rapidly, leaving you high and dry for those few days. So in order to prevent that from happening, where for a few days you have a very low level of progestogen, you tide over that period. You start either on the day of pickup or latest by the 3rd day of pickup.
Okay, thank you. Do you use progesterones for luteal phase support in IUI cycle?
Yes, I do. Yes, I do. And I usually use dydrogesterone. Okay, it is more convenient. And also, I think cost-wise, it is slightly less than other forms of what you call progestogen.
What doses do you use and when do you start? How long do you give it for?
IUI cycles.
Yes.
Okay, IUI cycle, I will usually either give it twice a day, dydrogesterone, one in the morning, one in the evening, and I will do a UPT between 14 to 21 days.
And so when do you start it?
I start it on the day I do the IUI.
Right. And what's your opinion in using all routes of progesterone for the luteal phase support? That means
Okay.
vaginal, oral,
Yes.
injection.
Yeah. Okay. You want my true answer? My true answer is I am also kiasu, you know.
So are we.
Yes, I will give you vaginal,
Yeah.
I will give you intramuscular, and I will give you oral.
Yeah.
Knowing fully well that all evidence points to vaginal.
Yes, I think many are doing the similar way, giving
Yes.
all sorts of things. Yeah.
Yeah.
What's your opinion on giving IM progesterone, like Hiprogen or Proluton, 250 milligram? That's what we have in Malaysia. When
Yeah.
did you start? Would you use it, and how long use it for?
Okay. My general practice, yes, I use Hyprogen. I used to use Proluton, but it became very difficult to get now. So I shifted over to Hyprogen, and I will give it every 3 days. That means twice a week. And I give it for about 12 weeks, until 12 weeks. Again, the luteoplacental shift.
When do you start?
I start on the day of transfer.
How about during preparation, 5 days before
I will be using the oral,
the
the
dydrogesterone or the
dydrogesterone.
eutrogestin?
Yes, yes.
Okay. How do you address the clumps issue? There's lots of women who use the gels and they complain a lot of clumps.
Okay, so it all depends on how we counsel the patient. Remember, just now I presented on the progesterone gel. Now it is inside a polymer, and this polymer is water soluble and very adhesive. So once you put it into the vagina, please tell the patient, sorry, walk around a bit, walk around for 20 minutes, walk around for 15 minutes, just move around so that it coats your whole vagina. Instead of when you put it into the vagina, it comes out as a single globule in your vagina. So it is not supposed to be in the form of a globule. It is supposed to coat the vaginal mucosa. So it becomes very thin. The absorption is much better and it does not clump together. When you put it in, and a lot of us will say, hey, after the embryo transfer, don't move. I want you to be static, to improve your implantation, all that. So they just put it in and they don't move. Actually, the advice is move. So you rub the vagina, use the vaginal mucosa to spread it like jam or butter throughout the vagina. Better absorption, less clumping.
Okay. And the other question is, if a patient undergoing FET requires twice daily dosing with the gel, when do you recommend them to dose the dose to be given? What's the schedule?
I will say, since you are doing it, this is by what you call rule of nose. If you are giving it, give 12 hourly. You cannot be giving, 1 o'clock and then 8 o'clock, and then you leave her exposed for so many hours with a lesser level. But I think once a day is sufficient. So far, I do not know. I'm getting pretty good results with once a day. I've never done twice a day. I don't know. What about you, Dr. Navdeep?
Well, generally, I prefer using twice a day.
Okay.
Yeah.
Yeah.
So for my
I don't
patients,
see anything wrong with it. Yeah. As long as we are able to maintain your level above what is necessary,
correct.
then it's fine. Giving a bit more does not harm.
I think aggressive progesterones aggressive luteal phase support, I think, is important, because many times people will decide that, let's do a more patient-friendly kind of luteal phase support by giving oral. So I feel, well, a combination therapy is better. That's what I have found.
Yeah. Yes, I agree with that, because if you take it oral, not only it cannot be measured in blood, the absorption depends on the person. As with every other thing we take, the absorption rate, the amount absorbed depends on that person's gut.
Correct, and also the absorption. If you give in the vaginal route, also the absorption will be different between patient to patient.
Yes.
Because we feel that one size tablet fits all. But actually, everybody is different size.
Yes.
You see,
Yes.
and
Agreed.
different metabolism, so the absorption may be a problem. And the problem is we don't know who will benefit with one, and then who will have two, who needs two. So I think it's always better to be more aggressive with the luteal phase support.
Yes, I agree with that statement.
All right. Any more questions? Hi, Dr. Tham. For the FT cycle, besides oral, vaginal, and intramuscular administration, do you practice intralipids?
Okay. Now, intralipid is a whole different topic.
Yes.
Intralipid is the immunomodulation in recurrent pregnancy, implantation failure, and all that. I think the last MSART I gave a talk on recurrent implantation failure. So intralipid is just the essential amino acids and all those things going in. And there are a lot of papers published previously. They did not say that it is significant. It may help. But now newer papers coming out from this year and end of last year says that intralipid shows no difference. That means they do not actually recommend it anymore. So it's passing over as a fad during that time. But of course, to answer your question, do I use it when my back is against the wall? I really don't know what is happening and what I can do. I am going to give you intralipid and give it the benefit of doubt.
Yeah, that's very correct. Same here too. You have no choice and you just give whatever you can. Yeah. And the next question, what optimum ET thickness for FET you practice?
There are so many papers which says that, few years ago and what they're recommending now is slightly different. Last time they used to say 7 millimeters, and then not more than 14 millimeters. It must have the triple line and this, blah, 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 blah. Now, most of the papers say the thickness is not very, very important. What you should go for is the trilaminar sign. So if you were to ask me what I practice, if you have the trilaminar sign, so be it. If you are 7, close to 7, I'm fine with it. I'm going to transfer. And what I can see is pregnancy rate never drop.
Yeah. Okay. Next question. What is your opinion about adding HCG for little support in HRT cycles where there is no corpus luteum?
Okay, you mean what we used to do previously, I started my life, my infancy was using HCG. I was taught about HCG in the early 2000s. And that was a time when we saw a lot of OHSS.
Yeah.
So HCG is on its way out, but then again, whenever I trigger you GnRH analog, I will add in a tiny weeny bit of HCG. If I use an agonist trigger, I will put it in a bit. There are some studies coming out to say that you may need the HCG drive a little bit. Otherwise, the outcome may not be that good. So with regards to whether I use HCG anymore as luteal phase support, no, I don't. We have got other good forms of progestogen.
Yeah, I agree. I don't use it too. And I usually trigger with agonist.
Yeah.
Okay, and the next one is, since we're speaking about implantation failure and thin endometrium, do you support the use of PRP or dispentazifuline?
Okay, that is that topic last year also. But anyway, PRP, it comes, it goes, I believe. But
Yeah.
so far I have some experience with PRP, but it is neither here nor there. You know, some seems to say it's beneficial. Some patients I can see slight change. Some I find that it's nothing. It did nothing. I have got patients coming with PRP to the ovary. I've got patients coming with PRP to the uterus. Some of them showed 1 or 2 more follicles. Pregnancy-wise, so far, I think not much of advantage. So, again, the same answer. If I got no other thing to offer, I will suggest it.
Yeah.
But if I have other things to offer, that's last on my list.
Yeah. Right. Okay. Next question. Is there such a thing as progesterone overload? I remember a paper mentioning a threshold of more than 100 millimole per liter as detrimental.
Yeah, they were talking about, you know, the Hyprogen and Proluton, the IM, when you give it for IVF as luteal phase support. Some people were saying that, you know, prolonged use of injectable progesterone has a detrimental effect on the fetus. So I think there were some papers published recently. So that's why some of the patients even query us, are you still giving me that? Because there was a bad write-up on these IM progestogens. So, of course, IM progestogen gives you a very high level, and the rest of it we cannot measure actually. The only one which is easily measured is your IM.
Yeah.
The rest of it, vaginal, oral, it's a bit difficult to measure. With regards to too much is detrimental. Well, I think to reach 100 is like, I don't know how much the patient is being given, you know.
Yeah, a lot.
Yeah, lots and lots of it. And before you can reach the 100, the patient will come to you, I am constipated for 1 month already. That's the main complaint of my patient.
Yeah.
So I think to overload, yes, please do not overload. We don't have any what you call any experience on what overload does.
True.
But we know very well it has sedative effect, GI effect, things like that.
Yeah. Thanks. Then the other question would be, what's the timing for PRP if needed? When do you use it?
Okay, PRP, if you want to do it, it has to be maybe 2 to 3 weeks prior to your stimulation.
That's
Or
to the ovary.
To the ovary. If let's say you want to do the transfer, you will do it in a preceding cycle. You give your PRP.
Yeah. During the endometrium stimulation, isn't it?
Yeah, just at the beginning. Yeah.
Yeah. Okay. And what's your opinion on what experience with genotropin growth hormone use?
I only have experience when I was attached in Australia, the growth hormone. To me personally, it's a very hyped up thing. Yeah, growth hormone is a very hyped up thing. It's very expensive.
Yeah.
And if your patient can afford it and you got no other option, I believe that is something like DHEA. Yeah, so give it a shot.
Totally agree. Yeah. Yeah, when you got nothing else to give, you have tried every single thing under the sun. You can try your PRP, your growth hormones, just do anything possible to help them.
Yeah.
Okay, the other one would be, what's your opinion on performing endometrial receptivity tests in recurrent implantation failure?
You mean your ERA test?
ERA,
I think you're talking about ERA.
ORA.
Okay, again, this if I think there was 1 or 2 years ago they were talking, or was it last year? Yeah, last year during one of the fertility conferences, somebody went up and talked. I forgot whether it was it an Israel guy or was it an American guy? And he was saying that all these things, it's a fad. It's something that somebody came in, marketed by the industry, and Now, what does the evidence say? Evidence say that you may use it. It's not
Yeah.
significant. Yeah.
Well, I use it quite frequently, and I do find it beneficial because many patients come in a history of failure, and then we find that the timing is displaced.
Yes.
You know, where they need 96 hours and 144 hours, and a lot of them got pregnant with those displaced kind of timing. So, my opinion, it makes the luteal phase support, or rather the preparation, a bit more
Easier, yeah.
objective. So, yeah. So
You know why?
I do use it frequently. Now there's a new one called the Aura, which is your blood test. It checks the mRNA. So I started using that, and yeah, so it seems to be giving a similar results.
Why I mentioned that I do not use it so often is whenever I get your ERA result, it tells you how many hours of progesterone you need, when to start, and all that, right? I find that the prediction is pretty close. They give you that graph, you know, yours and ours. I find that they almost put everything most of the time on top of my line. So I thought, okay. But there was one, like you said, she got pregnant because I was off by 1.5 days. And that was the one that was totally out from my prediction. The rest were similar. So yeah, you can use it. I'm not saying don't use it. Yeah, you can use it when you had, to me, 2 failures is enough. Do something.
Correct.
2 failures is enough. Yeah.
Yeah. The next question is I answer on behalf that in FET HRT cycle there is no ovulation, hence no corpus luteum. So HCG would not work to stimulate. I think this is a comment.
Yeah.
And then the next, any experience with stem cells?
Okay. I got no experience with stem cells. Zero experience.
I think stem cells should be cautious because the risk for cancer, it seems to be a bit higher. So I'm not convinced too that it works.
Yeah.
So I mean, there are a few types of stem cells. One you can inject it directly into the ovary, and other one's IV. So yeah, I have no experience in using them.
Yeah.
Okay, I think that's about it. Okay, there's no more questions. All right. So thank you very much, Dr. Tham, and I also like to extend our special appreciation to our co-organizer, Merck, and a heartfelt thanks to all of you for joining us and all the questions. And please remember to complete the post-webinar survey once we wrap up. Your feedback is very important to us.
Dr. Navdeep,
sorry?
Can I take 30 seconds?
Boleh.
I promo a bit.
Okay.
The EPO H-Star Hybrid Fertility course is on in September.
All right.
And I have put it in the ONG Kaki group and all the groups. So feel free. We have physical and we have hands-on. We have hands-on physical as well as we have virtual. It will be done in EPO. So please feel free.
When's the date? When will that be?
It will be on September. September. Oh my God, I'm looking at my own thing and I forgot about it. It will be in September. Yeah. So sorry, I think it's on the September 15 and 16.
Okay. All
yeah.
right.
So please search in the Facebook. We have got it in Facebook. Also.
All right. Yeah. And after that, don't forget MSART.
Yes, there's MSART too.
I look forward to seeing you all at the MSART 2024 conference. And thank you very much, everyone, and good night. Have a good day. Thank you very much, Tham.
Bye-bye.
And Merck. Okay, bye-bye. Good night.
Bye-bye.